Hello, and thank you for joining me today. My name is Henry Wilmot, and I was an intern the past summer for the Down syndrome program at Massachusetts General Hospital. And I'll be talking with you today about Down syndrome screening and diagnosis across Europe, Australia, New Zealand, and the United States. I'd like to start by thanking my collaborators, Gert de Graaf, Peter Van Kasteren, Frank Buckley, Brian Scottco for their help and guidance during this process. So to begin, when we're investigating prenatal screening and diagnostic services, we're looking to understand the policies that dictate access to prenatal screening and diagnosis services as they relate to Down syndrome. And from there, we're looking to see what questions we can raise based on a comprehensive listing of policies surrounding these services. And then from there, what trends may become apparent over the course of the past 30 years once we've compiled this complete piece of work. Our team's mission is the comprehensive review that covers each of these categories of prenatal services that might be offered to pregnant women in each country. And as well as that, we're looking to identify and define the availability of technology, the requirements for access of that technology, and the public coverage for that technology in each of those categories. So the way that we went about this is we performed a literature review that spanned peer-reviewed publications, collections of data published by international organizations, as well as any other collection of online source that detailed country-specific information relating to prenatal services. And we searched specifically looking at dates that told us something specific about policy at that time during a given time period, so we could nail down what exactly the offering was at any given moment over a course of the timeline. And the primary limitation to this review is a direct result of just availability of information that's presented online in a format that was accessible to our team. So if you have any more information that you think we may have missed today, I'll provide contact information at the end, and we would really appreciate it if you might reach out and share with us anything you might know. So here we're looking at pertinent vocabulary. The most important thing is to understand the difference between prenatal screening and prenatal diagnosis. Prenatal screening is going to be giving you a test that indicates a risk of Down syndrome prenatally. And prenatal diagnosis is going to be a chromosomal analysis that delivers a diagnosis of Down syndrome prenatally. And below, we have 4 examples of prenatal screening services that may be mentioned today in the presentation. This is nuchal translucency, which is an ultrasound assessment, AFP serum screening, which is a blood test, biochemical screening, which is also a blood test, and non-invasive prenatal testing, which is also a blood test. That's the most recent and considered to be fairly accurate and the most advanced technology. Now, for the results section, we're going to walk through 4 different graphical interpretations of data for European countries. And what we're going to see first is availability of prenatal screening services. Then we're going to be looking at the public coverage for those prenatal screening services in each of the same countries. We're then going to look at public coverage for prenatal diagnosis in the case of indicated risk, whether that's risk indicated from screening or risk indicated by any other number of factors. And then lastly, we're going to be looking at public coverage for abortion services in the case of a prenatal diagnosis of Down syndrome. And this is where services are legal. So if we indicate no coverage for a country where services are not legal, that's because in that situation, there would be no coverage even in that case, since it is illegal in that country. And so we've grouped those 2 together. So here to begin, we're looking at the availability of prenatal screening in Europe. We have green, which is indicating availability, red, which is indicating that it's not available, and orange, which is indicating that it's restricted. And this is at our starting time point of 1990. So you can see in the graph a fairly large amount of green. Screening is generally available over the majority of Europe. Moving into 2010, we see continued screening is very much so available, and we've actually shifted 7 countries have increased from having no availability to then having availability. So overall, that's a slight trend that we're seeing in increased availability. Next, we're looking at insurance coverage for prenatal screening for these countries. Once again, starting in 1990 for this graph, and we're going to move to 2010. But just to start, you can see much less availability when it comes to public coverage for funding compared to just the availability of the services in general. Moving on to 2010, we can see that there's a slight shift. It may be somewhat hard to see from the map since there are many countries, but we do know for a fact that 2 of these countries switched from no coverage to full, 3 of them switched from no coverage to partial, and 1 of them switched from partial to full coverage. So that's something to take note of. There is this shift, and then we can expect that that shift may continue into the future. So here we're going to take a closer look at just 3 countries, Australia, New Zealand, and the United States. So in Australia and New Zealand, it's fairly similar, having nuchal translucency available or biochemical screening in New Zealand's case in 1990. And then moving to 2010, you have an increase in the availability of different screening, more advanced screening techniques. NIPT is introduced in 2013 in Australia, and in New Zealand, you shift and you have also combined screening available. In Australia, we're going to note that there are medical rebates available for nuchal translucency, biochemical, and combined screening tests, but NIPT, being the most recently introduced technology, is entirely taken on by the patient, those costs. For New Zealand, we see that there is funding arrangements provided for nuchal translucency, but not biochemical or combined screening. So we're seeing that the more early established screening techniques tend to have more coverage, whereas the ones that were established later on and maybe more accurate testing are not covered. In the United States, we see that biochemical screening has been available for the entire time period. And in 2011, we do have the introduction of NIPT, or non-invasive prenatal testing, which is the most advanced screening technology that they have available. And for all dates, there is not universal public coverage in the United States, and that's something that we'll continue to see. So here now, we're going to look at these insurance coverage dates for prenatal diagnosis, and this is only in the case when there is indication for risk. So when you have an indication that you may want to pursue diagnostic testing, is it covered in that situation? So here we see once again, there is a large portion of Europe where there is full coverage. However, there is a significant portion where it's either partially covered or not covered at all in 1990. And as we move to 2010, we do see a shift where 5 countries have either shifted from no or partial to full, 2 of those being partial and 3 being no coverage to full. And then we see for 2 countries in particular, there is a full to no coverage shift and a full to partial shift, which is interesting since for the most part, we've seen almost entirely all countries have shifted from having less coverage to an increased amount of coverage. So that's something to notice and see if any other countries may follow that trend moving forward. Now here, we're going to look once again at Australia, New Zealand, and the United States. In Australia, they have a very prototypical situation where there's full coverage offered for individuals 37 years or older with a screening result indicating risk or with a family history of genetic disorder. These are really common risk factors that would offer you the accessibility of the prenatal diagnostic testing. And then coverage is associated with those when you do meet those risk factors. New Zealand, very similar. Full coverage will be offered for individuals 35 years or older, and or if there are clinical indications for diagnostic testing. In the United States, diagnosis is offered for individuals 35 years or older, or in the case of that indicated screening risk. But once again, similar to how we talked about before in the United States, only certain individuals qualify for government subsidized healthcare. And as a result, there is not universal coverage for this. So some individuals who may be seeking this may find that the cost that comes with it is a barrier to their access. Next, we're going to be looking at the public insurance coverage in the case of legal abortion in Europe. So this is once again, starting in 1990, we see that there is coverage, full and in many cases, partial coverage. And then after a second of looking at this graph, we'll move to 2010. And we see now that there is more coverage available. Some of that is a shift from partial to full. with one country, and then as well as countries that had no coverage available at all, shifting to that full coverage. So that's just another trend to take note of. And then for these three countries, once again, we're going to see that Australia does offer rebates through their national health insurance, which can cover a small portion of the given procedure. However, it's indicated that there may still be high costs associated. So that would be kind of one of these access or barriers that we're talking about, a barrier, this cost barrier, which is something our research group has found to be a significant factor that we must take in. So in New Zealand, we see that abortion services are indicated to be fully covered for at least the past decade. And that would be also an indication that most likely they were partially covered for some time before that, due to the long history of their national health insurance programs institution, which was well before 1990. So then moving on to the United States, we're going to see that the Hyde Amendment is a law passed in the United States, and it's passed yearly, that does restrict federal funding for abortion. However, individual states may use their own funds to set aside for the purpose of covering abortion services. So it's highly dependent on where you live in the United States, whether or not you may or may not have this barrier to access, that is the cost of accessing this service. So here, we're just going to talk about two countries very briefly. Belgium, we're going to look just kind of across their timeline. And you can see for prenatal screening that it is available during the entire timeline, but that there's an increase in the effectiveness or the advancement of the technology that's available. So we move from AFP serum screening, which is just one serum screening test, to the triple test, and then non-invasive prenatal testing. So each of these are more accurate risk assessments as you move along in the timeline. And then you see that there is full coverage for all of them. However, the introduction of NIPT does come with costs associated to it until it seems the government has decided that they value it to the point where they will start covering that service entirely in 2017. Prenatal diagnosis, we start with just the judgment of the obstetrician, which is not uncommon to see earlier on when guidelines had not necessarily been set out for what qualifies you for this diagnostic procedure. But then we see in 2009, they do have set requirements of 36 years or older, risk from prenatal screening, family history, or ultrasound scanning indication. These are all very common risk factors that will allow you to then access these prenatal diagnostic testing. And then we see for coverage, full coverage for diagnosis for this whole time, which is not uncommon. And then if we look at the abortion service timeline for the coverage of it, we see from 1990 to 2001, there is no coverage. But then moving forward from that point, there is full coverage. So once again, the same trend. We're seeing increased access, increased availability, less barriers to access any of these services as you move forward in a country like Belgium. Here in Albania, we're going to see a very different picture. For example, there is no screening available all the way until 2013, and there is no indication for prenatal diagnosis, and it's not available in 2004. Not necessarily common in the wider range of Europe, but something to take note of for a specific country. And then once it is introduced, as we see for prenatal screening in 2013, or introduced in 2004 for prenatal diagnosis, in both cases, in prenatal diagnosis, there is no coverage we see. And then for prenatal screening, only nuchal translucency is covered, which may not be the most accurate testing available for finding that risk factor. And then abortion service we see is entirely not covered during this time period. So this gives us an insight into the way that the country and their government views these services. And it may allow us to ask further questions about what's going on there and why they make those decisions to offer services in these ways. So here, when we get to our discussion, just what we're thinking about after we've presented all of this information and we've compiled this final amount of services that are available or not available, we're thinking about access. access to improved technology for prenatal screening has definitely expanded over time as we see countries offering new techniques and offering increased insurance coverage for those techniques. So over time, we're seeing that we're going from potentially just nuchal translucency to all the way up to these biochemical tests and non-invasive prenatal testing, which are going to give a more accurate risk factor and potentially help get to that decision of whether or not you want to proceed with diagnosis or maybe choose not to because of your faith in that risk factor. And along with that, the public insurance coverage for it has expanded over time. So we're seeing just an increase of access to services that are providing information, both from the outset of whether or not you can use it, and then whether or not it will be accessible to you based on cost, because cost is a really, really important factor in many people's lives. We also see that Central and Southern Europe generally tends to have a lower uptake of national insurance schemes that cover prenatal screening and diagnosis testing. And that's just something to take note of and see if potentially that means that we'll see a shift later on in the increase there. But it just is lagging a little bit behind. And then comparatively, we notice that more countries have taken up public coverage for diagnostic tests like amniocentesis or chorionic villus sampling, rather than tests like nuchal translucency or AFP serum screening. And so reason for that could possibly be that amniocentesis and chorionic villus sampling have been available for much longer than many of these screening technologies. And it could also be a result of the fact that they do provide a definitive diagnosis, whereas screening is for risk factors. But there's no one way to know for sure. But what we do know is that there is an increase in screening coverage as we move forward. And there may become a point where there is not a gap in any country between what's available in terms of screening versus diagnostic testing, and both are equally covered by the government. So that is my presentation. Thank you so much for joining me today. I really, really appreciate the opportunity. I'd like to thank the World Down Syndrome Congress for giving me this opportunity to speak with you today. It's truly been an honor, and I'm so grateful. I'd like to thank my collaborators one more time. Your mentorship has truly been special for me and has made a huge difference over the past couple months in my learning and growth as a researcher and student. And I'd like to thank all of my correspondents who I spoke with over email. A lot of this would not be possible without your eyes on the ground and providing me information that would not have otherwise been available. So thank you very much for that. I'd like to show my sources very quickly. All of these, all of this time and effort came from all of these places where information was already available, and we were able to put all of it together. And lastly, I'd like to just provide my contact information. Once again, my name is Henry Wilmot. My email is there on the screen. Please write it down if you'd like. If you have any questions or information for our team, please reach out. I would be extremely happy to hear from anyone about the presentation, any comments, and we'd love to hear any information that might help us provide a clearer picture about any given country that we may have not given full credit to. So thank you so much once again, and I hope everyone has a really wonderful day.